Amazing show tonight. We are going to be talking to you folks about the endometrial receptivity array, a total hot button topic for loads and loads of people who want to know about it. It's obviously a big thing in the infertility world, and I think we've got a really interesting program for you tonight to go over that. Of course, we'll be answering all your questions as we always do. And super excited to be back with you guys again, as always. Thank you so much for all of your follows. We are literally a couple people away from having 5,000 followers. So a lot of hard work and a lot of messages and a lot of Instagram posts, and we're almost there. So thank you for following. Thank you for attending these video sessions every week. Thank you for giving us the opportunity to help you on your journey. I do, while we're kind of spooling up, want to throw a totally anonymous shout out to absolutely one of the most amazing people I have ever had the opportunity to work with. So brief story, we had a patient who had trouble in a previous pregnancy and could not carry on her own, again, because of the risks that she posed to her pregnancy. And so she actually had her mom get involved, and we did IVF for her, took the embryos, put them into her mom, and her mom carried that baby all the way up to term and just delivered the other day, despite some significant medical complications that her mom had to go through. So I have nothing but awe and respect for that incredible, incredible woman. So if you're watching, or if your family is watching, congratulations from us at VRC, from everyone watching with us, of course, and God bless you. Thank you so much for what you did. The joy and the warmth and the love that you have brought to your own children is absolutely beyond words amazing. So big round of applause, loads of love and likes from everybody here for you. Thank you so much for what you did. I can't think of a more sacrificial thing a parent could do. So I am totally in awe of you. And I really have always thought my mom was the best, but you're definitely up there. So thank you for what you did. Thanks for bringing it to a very successful and happy conclusion, and much love to the family. Hopefully you guys are enjoying your baby and not watching our show right now. And speedy recovery. And if you need me, you have me on speed dial. So I am happy to accommodate anything you need. So let me know if there's ever anything we can do. I think we're almost there. Exciting news. Doug Ford is coming to Windsor. And so with some luck, maybe we'll get a chance to tug on his ear a little bit and ask if he can help us with funding. So we'll see if that works out. And hopefully the Premier will enjoy the tour of Windsor and bring us some good news. So we're working on that fast and furious, and the college is finally inspecting again. So we should be able to do our egg retrieval once they grant us, an inspection, which should be within the next couple of months. We're hoping. We have impressed upon them the importance of the inspection process for Windsor, because we don't really want patients going back and forth from Windsor to Toronto, to minimize the risk of transmission and spread of the virus, obviously. So we're working fast and furious for all you guys to get everything up and running. In the meantime, cycles are moving along at Create, and they are an amazing team of people there. So I really have fallen in love with all my teammates down there. We're starting to do some surgeries down there so that you guys won't have to wait a crazy year for surgery, which is absurd. And I apologize on behalf of all physicians, but we have nothing to do with surgery times. So we're getting to do some surgeries down there. And I'm actually hoping that if my embryologist says yes, we might actually set up doing some of the surgeries here in Windsor for you as well. And a huge shout out to our team in Sarnia, who's been doing an amazing job. Much love to you ladies, and James, who have put together a great program for us down there. And there will be some more highlights coming because we're expanding soon into some new locations. So I won't share any details quite yet, but when we're there, we'll let you know, and we'll bring you on board for that as well. Okay, so I think we've got our 8:05 time. I usually like to start after 5 minutes where everybody's had a chance to jump on board. And we'll go through it all and explain everything. So starting at the beginning, we picked a really hot topic, and I want to give you a little bit of history here. So I was at a conference in Chicago several years ago when a very prominent fertility specialist from Spain came up and started talking about this amazing program called the ERA, and that stood for Endometrial Receptivity Array. So the Endometrial Receptivity Array is a test where they test the lining of your uterus for several hundred genes and the levels of the activation of those genes to determine if your endometrium is receptive or not. So that's why they gave it the name of Endometrial Receptivity Array. And it uses some pretty sophisticated technology. The testing's all done in Spain. It's run by this company called iGenomics, and the company was really set up to take over this specific product, this specific topic. So for some reason, my Instagram phone is going dark every few seconds. So if you see me poking, that's why. So bottom line is they did an amazing job with this, and they got it, marketed. And they said, look, we've had people with thin linings. We've had people with linings that didn't look good. And so we couldn't get them pregnant. So then we did these endometrial receptivity arrays, and we popped embryos in, and they're all getting pregnant. And so they kind of turned the world upside down for IVF because everybody thought, wow, this is like the holy grail. Let's figure it out. So I'm not going to lie. I fell for it hook, line, and sinker and thought this sounds amazing. Let's do it. So we started doing it initially only for the people that failed. And then we thought, well, why are we only doing it for people that failed? Maybe we should be doing it for everybody. So then we started kind of promoting doing it for more and more people. As time went on, we realized it doesn't look like it's making as much of a difference as it should. And we would get people that were non-receptive, so you have to adjust the time. They'll tell you you're either pre-receptive or post-receptive or receptive. So if you're receptive, you're using the normal timing of progesterone. If you're pre-receptive, it means you need more progesterone. And if you're post-receptive, which we never saw, that means you're going too far. Your progesterone's too high or you're too loaded. You need to back up a day and put the embryo in it earlier, which is a little unusual. And even they themselves say very few patients are post-receptive. So we did it. And after a while, we realized this doesn't look like it's making a huge difference. So we kind of started to switch and started monitoring progesterone levels really carefully. And then we continued doing some ERA just to kind of see what would happen. And when we continued with the ERA tests, we found out that less than about 5% of the patients were asynchronous. So the whole idea behind this test is you've got this day 5 or day 6 embryo, and you've got to have 5 days of progesterone, and they have to be lined up. They got to be synchronous. So you're putting your day 5 embryo into your day 5 lining, and everything should work out perfect. Turns out that when we monitored the progesterone levels, less than 5% of our patients ended up having that asynchrony. And it's not a cheap test. They charge about $750 if I remember correctly. And we had to charge for the blood tests and the monitoring and the paperwork and checking all of your levels and telling you how much to take and what to do and so on. So, it was adding up to like $1,250 Canadian for the test. So we started shying away from it and moved away. And then I think it was about last year, it was one of the first topics we did with Fertility Fact or Fiction, where I showed you guys that not a single study out there actually supported the use of the ERA. Every single study that had been done up until that point had demonstrated absolutely no benefit to doing the test. There were some that were saying maybe it works, but none of them had actually showed a statistically significant improvement. So finally, after ages and ages, comes this study, which is titled A 5-Year Multi-Center Randomized Controlled Trial Comparing Personalized Frozen and Fresh Blastocyst Transfer in IVF. So this is the ERA test applied in order to create what they call a personalized embryo transfer. So they're marketing it towards people by saying, this is for your body, it's for your uterus, it's for your endometrium. This only applies to you, and it's only kind of good for you. So it's randomized, which is the kind of trial we want. And so they basically took the patients and they assigned them to one of 3 groups. One group got the personalized embryo transfer. one group with frozen embryos. One group got a frozen embryo transfer without it, and the other group was just the fresh embryo transfers. And then they compared the results between the three groups. So this was multi-center, done out of Spain, because iGenomics is from Spain. And they took participants who were undergoing IVF at their first appointment. They were 37 years of age or younger. Their body mass index was reasonable, 18.5 to 30, and they all had normal ovarian reserve. So keep in mind, this study only actually applies to the patients that meet those criteria. You can't take this and then say, oh, well, I'm 42 and I'm either too thin or too heavy, and I want this data to apply to me. It doesn't, because they didn't include those patients in it. They also didn't have men who had very severe male factors. So that's another element of it that's important for you to remember. Okay, so what did they do with all this? Well, they took this, and we may run out of batteries, guys, on our live studio here. So if you're watching on Facebook, you may lose us. Switch to the Instagram account. It's rahivictory.md. Because we may lose our battery supply here. Okay, so where did this leave us? Well, let me pull up the file, and hopefully I can show you guys this. And I want to be able to share the data. Here we go. Okay, so I'm going to blow that up. Okay, so if you're watching on Facebook, YouTube, you should be able to see this. I'm going to flip to table 1 really quickly. It's actually not table 1, it's the flow chart. So essentially, the very first thing they did was show who's who in the data. So there was no difference in any of the factors in terms of diagnosis, the number of people who had PCOS or endometriosis, male factor, and so on. They checked all of the groups, previous tries, previous miscarriages. It was all the same. There was no difference between any of those elements. So then they have this lovely flowchart, and this is where this study starts to fall apart. So the wheels do come off, and I want to warn you all in advance, okay? So they started off with 569 people in the study, but only 458 were actually randomized. Why? 111 needed to be excluded. 50 because they didn't meet the criteria, 43 because they declined to be involved, 8 for some reason were double randomized. I don't even know how you do that. And 9 had some kind of inclusion error. They don't specify what that was. So they ended up with 148 in the personalized embryo transfer, 154 in the frozen, and 156 in the fresh embryo transfers. So it's quite a complicated graph, but they lost a ton of the patients because many of them, almost half in each group, bailed and left the protocol for a variety of different reasons, whether it was an earlier embryo transfer or a later embryo transfer, or their progesterone was off, or whatever had happened, and they had to alter things. So they switched out of the protocol they were supposed to go into a different protocol. So what they ended up with from 148 people with the PET, they ended up with 81 that ended up going to the personalized embryo transfer, and then one more dropped out because they terminated the pregnancy, so you actually ended up with 80. From 154 in the FET group, they ended up with just 92 that actually followed that protocol. And from 156 in the fresh, they ended up with 94 that actually followed through with the protocol. So you're starting with this big number of over 500, and then you're ending up with 80, 92, and 94 that actually followed through on the treatment. So huge loss of patients. So right from the get-go, you got to know when you're going into this, you may not actually follow your protocol and spend all that money and then not do what the ERA test told you to do. And that's actually what this test is actually going to end up saying to you at the end of it all. Okay, so what happened when they actually studied it? Well, here are the cycle characteristics. And in the cycle characteristics, what they ended up showing, which is important, is that there was a difference, a statistical difference, between the number of patients with day 5 and day 6 embryos. So you can see in the frozen embryo transfer group, there were 11.5% with day 6 embryos, only 4.1% with day 6 embryos that got transferred in the fresh embryo transfer group. Probably makes sense. Normally, we don't wait till day 6 to do fresh embryo transfers. And then as well, the day 5 embryos were 69.5% in the personalized embryo transfer group, but then 75.7 and 82.1 in the other two groups, the frozen and the fresh, respectively. So there were differences in the number of embryos that were day 5 and day 6. And if you guys remember or were watching a couple weeks ago when we did the presentation for Fertility Fact or Fiction talking about the day 5 embryos versus the day 6 embryos, the day 6 embryos are actually supposed to go in after 6 days of progesterone instead of 5. So there are differences here that they didn't even acknowledge in the analysis, okay? That's huge because you're ignoring valuable data and it undermines the results. It undermines what you're seeing in the report. Okay, so where's the nitty gritty? It is right here for you all to see. So if you're watching on the YouTube, Facebook, and Twitter feeds, you're gonna see it. For those of you who are watching on Instagram, you're gonna have to take my word for it, okay? So did they see a difference in the protocol analysis? So they analyzed it by intention to treat, which is the right way to do it statistically. So to the group you were assigned to, not what you actually ended up doing, but what happened to you based on the group you were assigned to? Well, based on the group you were actually assigned to, you had no difference in pregnancy rate, no difference in implantation rate, and no difference in live birth rate on your first transfer. So on transfer number 1, it's totally useless to you. And that was the same between all the groups, whether they compared the personalized to the frozen or the personalized to the fresh, okay? There is no difference in those groups. What they did see, however, was a huge increase in the number of miscarriages in the patients that had done the personalized embryo transfer versus the ones that had not. So it was a 3.5-fold increase in your risk of miscarriage compared to the patients that were just going for a fresh embryo transfer. So in other words, if you do your ERA test and you go through the whole process and you follow their instructions, your miscarriage rate was 3.5-fold higher, 350% higher rate of miscarriage than not doing the ERA test. So then they said, well, what if we look at it by doing more cycles? What happens when we look at all of the cycles that were done over the course of a year? So now they saw a difference in the cumulative, they called it the cumulative pregnancy rate. So yes, there was an increase, 17% and 16% for versus frozen and versus fresh. So a slight increase. And then they analyzed the live birth rate and there's no difference. So when you analyze this as a per protocol assessment, there is absolutely no difference between the two groups, between the personalized embryo transfer and the frozen embryo transfer or the fresh. They all had the same live birth rate. Didn't matter if you did a personalized, didn't matter if you just skipped it and did it the normal way. Whatever way ended up, you got the same outcome at the end of it all, and the results ended up being the same. So, important thing here is when you statistically look at this using the correct statistical technique, there is no value to doing the ERA test, and this is from the people that did the ERA test, okay? They own this test. What did they show? Again, in the cumulative one, a higher risk of miscarriages. How high? 4.26. That's a 426% risk of, or increased risk of miscarriage compared to the baseline. So a huge jump forward in your miscarriage risk if you did the personalized embryo transfer versus the fresh. Now, both of those miscarriage risks were for the frozen with the personalized versus the fresh embryo transfer. But they didn't see it with the frozen embryo transfer. So not useful. So then these guys decided, well, we're not seeing the results that we want. Let's look at it for the groups that actually did what they were supposed to do. So this is instead of intention to treat, this is the actual protocol that they followed, okay? So when they looked at the protocol that they were supposed to follow, again, there is no difference on the first embryo transfer for live birth rate. They did see a borderline increase, and it was borderline, it's not statistically significant in pregnancy. They did see a significant increase in implantation, but there is no difference in live birth. The only time they see a difference in live birth is if you go down to the cumulative pregnancy rate and you're looking at the live birth rate and you're comparing personalized for the ones that actually followed through on their protocol versus the frozen or versus the fresh. Now, versus frozen, it is statistically significant, but the p-value is 0.04. It has to be less than 0.05. So again, it's kind of questionable. When they compared it to the fresh, it was highly significant, 0.003. But you're cheating because you're looking at it as a per protocol analysis, and that is not statistically valid. The statistical analysis says you must do it as an intention to treat analysis. And based on the intention to treat, because so many people fall out of the model, you don't have the data to analyze it any other way than saying, if we started with this plan, where are we going to end up? Not, hey, we started with this plan, but then it totally went screwy. Half the patients fell off. And so we're just going to cherry pick the good ones and then decide what to do with that data. That data does show a difference, but that data is not valid. So basically, the bottom line is this does not demonstrate a statistically significant difference when you're analyzing the data appropriately. Okay, so one other part to this that's Yeah, there we go. Sorry, guys. Sorry, Julie. Thanks for letting us know. Okay. If you know you are a poor responder to IVF medication, is there anything you can do before or during your IVF cycle to help shorten duration or reduce meds? Testosterone has been proven to increase the number of eggs. DHEA has been proven to increase the number of eggs. Human growth hormone can increase the number of eggs, but none of them have ever been shown to increase the live birth rate. There's nothing you can really do to shorten other than live healthy, take the Mediterranean diet, make sure your weight's appropriate, lots of vitamins, stuff like that. But none of this stuff has ever been demonstrated to reduce your risk of going over the amount of time that you want to go over, or that you want to be within, I should say, or to increase your live birth rate. So if you're a poor responder, the truth is your best bet is keep trying, or choose to engage in a donor. There is no single protocol ever that has ever been demonstrated anywhere in the literature that has shown that one protocol or one approach is better than any other for a poor responder. In fact, if anything, I'm kind of more of a fan of just doing natural cycle IVF for some of those patients because you save so much money on the meds. And it makes more sense to try more times than to pour thousands of dollars into getting 2 eggs. You may as well, plus all the shots you got to take, you may as well just do 2 cycles. It's going to cost you the same. We only charge $6,000 Canadian to do a natural cycle IVF. So that's a great approach with a really reasonable rate of yield and outcome. So that's probably a more logical approach than trying this with doing, $5,000, $6,000, $7,000 worth of medication. That study was done wrong for another reason. It should have only been done on recurrent implantation failure. For the ERA test, the recurrent implantation failures, I agree, that would probably be the best group of patients to do it on. They were trying to demonstrate that this applies to everybody. And if you actually read the study, when they go through what they report, they actually skip the fact in the main paragraph that in the intention to treat protocol and analysis, the live birth rate was no different. They do say the clinical pregnancy rate was different, but they skip the whole fact that the live birth rate was no different. So they're still trying to sell this as viable when in reality it absolutely is not. I have a personal communication from the head of the company where he tried to explain to me that it was valuable and worked based on a study that actually showed no statistical significance. I wrote back to the rep and said, please don't ever have this guy communicate with anyone ever again, because what he's telling me is just utter nonsense. It made no sense at all. Okay, so someone is asking from Facebook. Sorry, let's put it up. Let me get rid of this guy. Not sure if you answered. Putting here, would you suggest a 30-year-old woman with tubal infertility to do PGS testing on her 10 amazing grade embryos? No. If you're 30 years old, PGT, much like the ERA test, does not help you. In fact, it's probably detrimental because you're going to lose valuable embryos. And that was shown in the STAR trial, which was published recently. And we actually reviewed on fertility factor fiction again. So go back and look at that trial. The STAR trial demonstrates that pre-implantation genetic testing for aneuploidy is not beneficial for young women. So if you are 30, you absolutely should not be doing PGTA, especially if the embryo quality is great. Do not do it. It's a waste of time. It's a waste of money. You're just going to lose valuable embryos. Do you offer NIPT, that's non-invasive prenatal tests for checking for Down syndrome and stuff? For example, Panorama, let's switch to this one, which includes sex determination at 8 weeks for parents who would like it. Yeah, so we don't do it at 8. I think they started at 10. I certainly have no issues with parents that want to know the sex of the child as long as you're not planning to terminate based on the sex of the child, because that would be horribly, horribly unethical and wrong. And in fact, it's illegal. So if you're trying to determine the sex of the child because you want to paint the room a certain color, absolutely go for it. And you can do it. You don't even need us. You can literally walk into the lab and order the test because you're paying for it. But would I do it for someone that needs to know because they want to do family balancing or don't want a sex of a baby of a particular gender or sex? Hell no. I mean, that's totally unethical and not okay. So those patients should not be getting it done. What are some good questions to ask our doctor before an FET? Lots of questions. So you want to know your vitamin D level. You want to know what protocol they are using. Are they measuring your vitamin levels? Are they using down regulation or are they doing it natural? So are they using your natural period or are they putting you on meds? Are they using letrozole, which we've reviewed here? It does improve your success rates. Are they giving you probiotics? Are they paying attention to the vaginal microbiome? Do they check your progesterone levels? How thick do they like your endometrium to be? Are they monitoring to see if your endometrium shrinks or compacts after you've started your progesterone? And are they monitoring for contractions? So if your uterus is contracting when you put in an embryo, that embryo is going to float on by. And then you got to see if they're following this new study we reviewed a couple weeks ago, which says that if you have a day 5 embryo, it can go in after 5 days. If you have a day 6 embryo and you want to reduce your miscarriage rates, it should go in after 6 days of progesterone. So those are just some of the questions you need to ask. You need to know what they do for the retroverted uterus. So if a woman's lying flat, her head is on this side, my left, and the feet are on the right, then what you're going to end up with is a uterus that's either tipped up towards her belly button, so abdomen's here, bottom's down here. It'll be mid position. It can be tilted slightly back, or some of them are curled right over. If you are back or curled right over, it is a very difficult embryo transfer. And for those patients, if you've got a really good skilled technologist or ultrasonographer or the physician plus the embryologist, you can do a transvaginal ultrasound guided embryo transfer. And when we have those retroverted uteri, that's what we do. So we use the transvaginal approach, which allows us to beautifully visualize where the embryo is going instead of totally struggling to figure out where the embryo is going. And that's the way that we make it work. And it tends to work out really, really well. We've had very, very good success rates doing that transvaginal transfer. It's not easy. It's very sophisticated. It's super crowded to get 3 sets of hands in there. But we have managed to do it with 2 sets of hands. I manage the ultrasound and the outer catheter, and then my embryologist will do the afterload technique, bring in the embryo and put it in. So those are the things you need to know to decide if it's a good thing for you or not. So ask your physician what they do. Hi, if you were taking oral medications for IUI, do you still monitor ultrasound blood work for ovulation or just at home? What happens if you ovulate late on Friday or Saturday? Okay, so if you are doing oral medications, the research shows that there is no benefit to us monitoring you. In fact, it cuts your chances in half if we trigger you, unless you are not releasing the egg on your own, in which case you have to be monitored. But if you are ovulating regularly on letrozole or Clomid, the oral medications that we use, then there is absolutely zero benefit to monitoring you. It's unnecessary. So just go ahead and use the ovulation predictor kit. If you are not ovulating on those meds, yes, of course, we need to monitor you. We have a hotline number, so if you can't get a hold of a person, you call the emergency number. The girls should be giving it to you at the start of your cycle. You just call that number and get a hold of us. You can always reach me on Instagram. I'm pretty much checking it 24/7. And by doing that, we can reach out to you and help you out and give you whatever information you need. And we are open 7 days a week for doing insemination, so it's not a problem. Any day is a possibility. So hopefully that answers that one. Interesting, I've had 4 transfers. First, negative beta, did ERA pre-receptive. Next transfer, miscarriage, which is what the study shows. Next transfer, 2 embryos, negative beta. Now we are going back to our normal 5-day PIO. You know what? I've had the exact same experience. I've had patients where we did the ERA. It said, do it this way, do it that way. It didn't work. We redid it. One poor woman did it more times than I care to admit. We even had ERA do it for free once because it didn't make sense what they kept telling us. It was different every time. And then we finally said, screw this. We're just doing it the good old-fashioned way. And that was the time she got pregnant and had a perfectly beautiful baby. So I am not a believer. I'm not a believer at all. Facebook. Oh, here's a great question, guys. Would you consider it normal if someone was 7 weeks pregnant and suddenly woke up without any pregnancy symptoms? It's not necessarily normal, but it's not necessarily ominous. If you're concerned, it's easy. You need to monitor your betas and get an ultrasound. So at 7 weeks, there should be a viable fetus there with a fetal heartbeat. So ultrasound will prove to you that everything's okay. I wish I could give you some other kind of reassurance. It's really difficult to do that without actually knowing that everything's okay. So yes, in those circumstances, I would say go get checked. And, for the patients that are with us, just don't hesitate. Call us in the next day and we'll always squeeze you in when it's that kind of urgency or concern that something is wrong. I'm here at almost 9 o'clock at night. So if I have to stay an extra 15 minutes at the end of the day or even hours at the end of the day, I always do. So don't hesitate. If you need us, reach out and we'll be here for you for sure. Now I feel like I wasted my time and money because the ERA test was pushed on me before all this research. Yeah, I mean, like I said, I fell for it hook, line, and sinker. And I told patients that it made sense because it did. What they told us made sense. But this is the reason I have this show, because after that experience, I realized we can't jump into things until we know that they actually make sense. And that same company sells other products like testing for bacterial levels in your uterus, which is also nonsense because they have absolutely no way of telling you what to do when you find that you're not normal in your bacterial content of your uterus. So they said, at the start of their presentation for that, they said, we know from our studies that what's in the vagina is not the same as what's in the uterus. And so we went and studied what's in the uterus. And so we have this biopsy and you send it off and we can tell you what's in your uterus. And I said, great. What do I do if I find out there's something wrong? And they said, you give antibiotics and then you put a tampon in the vagina that's soaked with the right bacteria. And I said, wait a minute. Didn't you just tell me at the start that what's in the vagina isn't what's in the uterus? And they said, yeah. And I said, well, then why is putting something in the vagina going to get into the uterus? They had no answer because they hadn't even thought it through yet. So, don't jump into stuff. I feel bad everybody wasted money. It did work for some of our patients, so I guess it has on some level some benefit. But really, it should only be used for patients where the lining is thin and they're thinking surrogate and you want to see if they can accept an embryo or not. And I will tell you, I have done that in a lady who had one and only one good embryo. Her lining would not thicken no matter what we tried. We did the ERA. They said it was receptive. We put in the embryo and she did get pregnant and have her baby. So maybe it's good for that. Here's one. If I had a failed transfer with a normal protocol, but then a successful transfer after ERA, extra 5 hours of progesterone, plus treatment for endometritis, what would you recommend for next transfer? I would do the exact same thing you did last time. But 5 hours is not a big deal when we're talking about ERA. ERA is really, even though they claim there's this short little window, that clearly isn't the case because there are studies that show that there's no difference using a day 5 embryo transferring on day 5 or day 6 of progesterone. So this whole idea that there's this 6 hour window they talk about, it's nonsensical. It's not actually true, at least not biologically true. So you can follow the same protocol we did last time and get the exact same result. And I know who you are, and I love you. Okay, so let's go over here. My doctor at RMA is saying the same thing about the research. Why aren't these research studies done before they use us as a guinea pig? That has 100% to do with money. So that's why. And I'm glad your doctor at RMA is saying the same thing. RMA is actually now tied into IVI because they're one company, IVI, and IVI is the company that iGenomics comes from. So IVI and RMA merged. So I'm actually really happy to hear RMA says don't use it, but IVI is definitely promoting it. So that's where it comes from. Anything you can do or take to improve egg quality. The only thing that improves egg quality is coenzyme Q10, and we don't actually know that that improves egg quality, but we think it does. Aside from that, make sure your vitamin levels are high, make sure your antioxidant levels are high, make sure your oxidant levels are low. Plastics, chemicals, exposures, smoking, drinking, drug use, like those all have to go. Your weight has to be controlled. Your diet should be healthy. You want to stay away from high levels of cholesterol and sugar. Anything that creates inflammation in your body, it will be detrimental to your fertility. So that's all really important. Where are we at for time? Oh, we still got some time. How can a Lupron depot benefit someone without endo? Well, first of all, it's hard to know if you have endo unless you've had surgery. And secondly, it still has impact on many different aspects of the function of your endometrium, including the immune system in the endometrium, the chance that you'll spontaneously ovulate, which can totally mess up your cycle. So there are several benefits to using Lupron. It also allows us to program things. We don't have to worry about whether or not you're going to have breakaway follicles or breakaway ovulation, that kind of thing. Should progesterone levels be checked through blood work after starting PIO before FET? I believe so, yes. I do think that patients should have their progesterone levels checked when they are going through a cycle. So what we do is we start your proj, and then we check it, make sure it's negative. Then we start your progesterone, and then 3 days after we check your progesterone level, and we adjust it if we have to get it into the right range, and then we'll recheck it. And then we go ahead and do your embryo transfer. And then we check it again after we've transferred your embryo to make sure it's staying in the right range. So we're really careful about the progesterone levels. Other people aren't, and they have good success rates, but for us, we want to make sure it's okay. What are your post-FET instructions? It seems to vary between doctors. Yes, it does. Our instructions, don't do anything crazy, but also do whatever stresses you the least. So don't go do something nuts, like don't jump out of a plane or go to spin class or hot yoga. But, average stuff is fine. Lots of people ask about intercourse. I wouldn't practice 50 Shades of Gray, but I don't think it's a problem if you want to have gentle sex. I always tell people don't have sex, make love. So that's probably okay as long as it's gentle. And otherwise, just stay away from everything bad. No smoking, no drinking, no drug use, no extremes of anything, food, temperature, activity level, everything just kind of like low key. Take it easy. That's basically it. Facebook. A lot of clinics in the USA have started incorporating priming with HCG before a cycle. I think studies are a bit conflicting whether it works or not. Does it hurt to try? I'm not sure what you mean by priming with HCG before a cycle. If you mean giving someone HCG before you start their stimulation, I'm not familiar with that. I haven't heard of that before. If you mean doing it before an embryo transfer, we did review a study a while back, gosh, that was months ago, that shows that an HCG wash prior to frozen embryo transfer actually does improve the success rates. And we do it in the patients who have failed. So yeah, that's very doable. And I've had good success with that as well. So if that's what you're talking about, continuous HCG does not help. That's been shown. It's been studied extensively, and there's lots of studies that say that doesn't work. But I would say that doing an HCG wash may be beneficial. It's from a meta-analysis, so that's where the data came from. You got to keep that in mind. Would PGT for 30-year-olds still not be necessary if they have diminished ovarian reserve and a history of loss? If you have recurrent pregnancy loss, there is evidence that shows that pre-implantation genetic testing can be beneficial. If you have diminished ovarian reserve, so your ovaries are not acting like the ovaries of a 30-year-old, you need to consider it. it may not necessarily help you, and there is no data on that specific group, but it might be beneficial. I don't know. No one does. There is a study I have not reviewed yet with you guys, but I did read, which is, I think, still in press, which shows that for guys that have severe male factor, again, pre-implantation genetic testing did not improve the outcomes. So even if you had really bad male factor as a component, you would think bad sperm, maybe bad embryo. Reality is it made no difference. It did not improve the success rate. So I'm not sure it will work. Our Facebook patient or individual is saying taking HCG before you start stimulation. I'm going to have to look that up, Andrea. I've never heard of that before, so I'll check it out. Yeah, certainly no one I know of is doing that. And biologically, it doesn't make a ton of sense. Why would you want the body to think you're pregnant before you're trying to make eggs? Because when your body thinks you're pregnant, you are most definitely not producing eggs. Now, if they're looking for it from the standpoint of LH activity, because it's similar, that too doesn't make a ton of sense and shouldn't be any different than taking something like DHEA or testosterone. So all of those kind of things need to be more carefully looked at. None of them has ever been proven to impact live birth. I'm certainly not familiar with any data recently about doing HCG before your stim. But thanks for letting us know. When should the compaction ultrasound be done for an FET? We do it on the third day. That's what this study said. So that's what we do. So you take 3 days of progesterone, and then we bring you in and we check the compaction. Is it considered a poor response if you required very high doses of IVF meds and 13 days, I'm assuming, of stimulation, but 12 eggs were retrieved? No, but they shouldn't have gone 13 days. Ideally, you do it before then, and we reviewed that data here a few weeks back, about a month and a half, 2 months ago. So longer cycles do result in lower success rates. So you do need to be cautious about how long you're going. It is better to have less eggs earlier than to have more eggs later. So keep that in mind when you go through. Do you recommend Valium the day of the transfer? Yeah, if you're anxious, yes. If you're not anxious, no. Your sense of calm at the time of your embryo transfer is relevant. Anxiety, psychological stress, all of that stuff is known to reduce your success rates. So we don't want you stressed. So if you're going to come in and be quivering, it's not even worth doing it, guys. So if you're going to come in nice and calm, great. If you're going to come in not so calm and you would be calm on Valium, take the Valium. I'd rather have you high and calm than stressed and sober. So keep that in mind. Can you speak on endometrial scratching? Oh, dear God, no. Would it be beneficial for a thick uterine lining? Okay, Kel. So the problem with this is that there are like literally 50 studies on this topic. We even reviewed one on Fact or Fiction, and I reviewed it, and that study showed that there was no benefit. And then a week later, they said there was. And then like 2 weeks later, another study said there wasn't. I think the jury's still out. The appropriate large-scale randomized controlled trial where everybody was tossed in, it didn't matter who you were, they did the biopsy, found out what was going on, actually did something with the results, has just not been done. So we use it from time to time, but not frequently. And it's painful, it's uncomfortable, it's a bit traumatic. Certainly, if you have a thick lining, that needs to be dealt with based on its thickness. A lining that's too thick is not necessarily good for embryo implantation. So less estrogen, whatever way necessary, maybe use letrozole to thin it out a bit. Why do some doctors decrease estrase 5 days before FET versus increase before the transfer? I don't know why anyone would decrease. Although if you're not compacting your lining, you're actually supposed to decrease the estrogen. That's how we do it. So if I see that your lining is not shrinking in response to the progesterone, You don't crank up the progesterone, you actually dial down the estrogen. So that might be why they're doing it, but as a general rule, and certainly before the Compaction study, we weren't doing that at all. So we don't decrease estrogen. I've had 3 failed transfers with 23-year-old donor eggs. Oh, I am so sorry. 1 negative beta and 2 chemicals. What would you suggest for next step as far as testing, if not an ERA? Extensive testing of your immune system and of your endometrium. I am kind of a fan of this new test called Fertility. I've talked to you guys about it before. It's also known as Locus Medicus. I think they must have just recently been bought out. You take a biopsy of your uterus, you send it to these guys. They actually tell you something practical. Is there bad bacteria in the lining of your uterus? Gardnerella, atopium, various viruses, chlamydia. They've got a whole bunch of them in there that they look up to 12, including some viruses like herpes. And you can add on human herpes virus 6. If you have any of those in there, those have to be dealt with before you get pregnant. And we have been doing quite a bit of it and finding a ton of patients are coming back positive. So I think that actually makes an enormous difference in your outcome and your success rate. So I think those all need to be carefully addressed and dealt with. So I would definitely do that. You might want to see a reproductive immunologist. We use Fred Dizaneku and Chloe Remain. Friends of mine who are amazing, amazing people, very bright, very like-minded. They care about the patients. They're not about spending unnecessary dollars. They take care of you because they want to take care of people. So I really love them. Shout out to them. They're probably driving back from Quebec right now. So have a safe journey, guys. Hi, could you please save your live? Thank you. So the live will be up on Instagram for 24 hours, and it's always on our YouTube channel, www.youtube.com/Dr. Victory, Dr. Victory. You can find us there. We've got all of Fact or Fiction there. You can check it out there. And I think it's on Facebook as well. Can I transfer 2 embryos from frozen together on the second FET, or should I keep it as my last resort? Oh, hi. Yeah, you can transfer 2. Just be prepared for twins. If we still have a single, I'd probably prefer to put in the single and keep the double for a last resort. There is a great study that I'm hoping to review with you guys maybe, which shows that if you put in a poor quality embryo with a good quality embryo, it does not impact the success rate of the good quality embryo. So not an unreasonable thing to do. Do I recommend PIO shots in the morning or evening? So it has to be done based on the timing of your transfer. So if they're anticipating your transfer is going to be in the morning, you got to do it in the morning so that you've finished your 120 hours by the morning. So the timing is important up to a point. So if they're planning to do a nighttime transfer, which no one does, then you need to start it in the evening. But if you're planning to do a morning transfer, you have to start it in the morning. Last question. Well, actually, we don't even have time. Sorry, guys. We've run out of time. I love you all. Have a great week. We will try and keep track of the questions, and we will come back. Angel Dreams, message me and I'll answer that question. Same thing for you, Katie. I think that was everybody. Yeah. So have a great night, guys. We will talk again soon. And Fertility Fact or Fiction loves you. We're getting to 5,000, so thank you very much for that. And we'll be in touch. Have a great night, guys.